Good day, we're Group 8 and we're here to present an interactive discussion about an emergency case. For history, we had our patient, FG, a 56-year-old male with a chief complaint of chest pain radiating to the back. His history shows that he has an uncontrolled blood pressure and presents with tingling sensation at the lower extremities.
For the radiographic findings, so this is the posterior anterior view of the chest x-ray of a normal person and our patient. Normally, the level of the right hemidiaphragm should be at the level of the 10th rib and is usually one intercostal space higher than the left. The diaphragm is dome-shaped and the costophrenic sulci are sharp. The ribs and intercostal spaces are equal and symmetrical, and one should also see the cardiac silhouette clearly. So normally we would see the superior vena cava, the right atrium, and the inferior vena cava making up the right border, and the aortic knob, the pulmonary trunk, and the left ventricle making up the left border. The size of the heart should also be evaluated, in which the cardiac width should be less than or equal to 50% of the thoracic width. The vascular markings normally become smaller in diameter towards the periphery. The patient's radiograph shows the right hemidiaphragm still at the level of the 10th rib with sharp costophrenic sulcus. However, the left hemidiaphragm and costophrenic sulcus are obliterated, indicating possible left pleural effusion. The intercostal spaces look wide and the cardiac shadow is seen. The ascending aorta is visible on the right heart border. The aortic arch and the descending aorta are dilated. So this is the lateral chest x-ray of a normal person and our patient. Normally, we see the cardiac silhouette with the right ventricle as the anterior border and the left atrium as the posterior border. The retrosternal space is a clear space anterior to the shadow of the ascending aorta. The hilar region is made up of pulmonary arteries, and normally no mass should be seen. We can also see the thoracic spine. So the average normal aortic width for the ascending aorta is 3.5 centimeters, the aortic arch is 2.5 centimeters, and the descending thoracic aorta is 2 centimeters. As seen in the patient's radiograph, the most obvious finding is the markedly dilated descending aorta.
This slide shows the comparison between a normal CT scan and that of our patient. The most obvious finding is the presence of a very large aorta. Normally, an aorta has a diameter of 2.5 centimeters, and a diameter greater than 4 centimeters is already considered a dilated aorta. And in the case of our patient, it reached a diameter of 7.37 centimeters. Aside from a dilated aorta, other CT scan findings shows a contrast-enhanced blood in the lumen and the presence of a mural thrombus. There are also notable hyperdense calcifications in the wall of the great vessel due to atherosclerotic plaques, as pointed out by the red arrows.
Okay, for the differential diagnosis.
For our differential diagnosis, we have your anterior mediastinal mass and your aortic aneurysm.
So for the anterior mediastinal mass, first let us review the basic anatomy of the mediastinum. Since our topic is anterior mediastinal mass, let us focus on the anterior mediastinum represented as the part with the violet color. Now, the boundaries of the anterior mediastinum are the sternum anteriorly, and the great vessels, brachiocephalic veins, pericardium, and ascending aorta posteriorly. It normally contains only the thymus, lymph nodes, fat, and some small vessels. Take note that anterior mediastinal masses may arise from any of these structures. Masses in this region may present with symptoms due to compression of the airways or the superior vena cava, or because of the compression of nerves such as your vagus or recurrent laryngeal nerve. Thus, this might present with pain, paralysis of the diaphragm or vocal cords, arrhythmias, superior vena cava syndrome, dyspnea or cough, or dysphagia. As you can see in the table below, those are the most common anterior mediastinal masses with their corresponding classes. But the most common lesions that you will see in the anterior mediastinum will either be in thymic or lymph node in origin, and we may remember them using the 4Ts as a mnemonic for anterior mediastinal masses. So namely, they are your thymus, teratoma, thyroid, or terrible lymphoma. So for this slide, this is just to help us in narrowing down the mass lesion on the radiograph on lateral view. So we can separate the anterior and middle compartments by drawing an imaginary line anterior to the trachea and posteriorly to the inferior vena cava, while the middle and posterior compartments can be separated by an imaginary line passing 1 centimeter posteriorly to the anterior border of the vertebral bodies. With this division, this allows us to make a more narrow differential diagnosis. So this slide just shows us some particular signs that can be seen in common radiographs showing anterior mediastinal masses. So first is your displaced anterior junction line. This is the line represented as the red line on the radiograph. If that line is displaced posteriorly, we can rule in the diagnosis of an anterior mass. Next is your cardiophrenic angle. This is the angle between your heart and diaphragm that can be seen in anterior view. If that is obliterated, we can opt to rule in the diagnosis of an anterior mass. Next is your obliterated retrosternal clear space, which is not so helpful anymore, since some of the patients, especially the obese ones, may fill the retrosternal space with fat. Next is your hilum overlay sign. This can be seen when there is a mediastinal mass and you can see the hilar vessels through this mass. So therefore, you know that the mass does not arise from the hilum. And lastly, the effacement of the ascending aorta, which can be due to the compression of the mass. So this slide just shows us a posterior-anterior chest radiograph that shows us a very large mass extending laterally from the left side of the mediastinum. This can be seen with blue arrows. So this slide just shows us a chest X-ray showing the widening of the superior mediastinum secondary to a large soft tissue density mass to the left of the trachea, which can be seen with the yellow arrows, and the displacement of the trachea to the right side, which is represented with the red arrows. So this slide just shows us that the lateral X-ray view can confirm the location of an anterior mediastinal mass. So the mass is outlined in yellow and is displacing the trachea posteriorly, which can be seen with blue lines. Now notice the patient's radiograph on lateral view seems not to have an obliterated retrosternal space. But then again, as we said a while ago, an obliterated retrosternal clear space is not so helpful anymore since most of the patients, especially the obese ones, may fill the retrosternal space with fat. So this slide just shows us that the mass of the patient is definitely not from the anterior mediastinum. But we can take this opportunity to compare the CT scan of a patient with anterior mediastinal mass as seen with the left picture.
Another differential diagnosis is aortic aneurysm. Atherosclerotic aortic aneurysms are most common in the infrarenal abdominal aorta, which is the typical location of an abdominal aortic aneurysm. However, while thoracic aneurysms are less common, they have an increased risk of mortality due to its risk of rupture or dissection. Aortic aneurysm is defined as being greater than 5 centimeters in diameter in the ascending aorta, greater than 4 centimeters in the descending thoracic aorta, and greater than 3 centimeters in the abdominal aorta. Gradual leakage often precedes fatal rupture, and the greater its diameter, the more likely it will rupture, which will be explained later in the pathophysiology. Aortic aneurysms are commonly asymptomatic and are found incidentally. However, when it becomes symptomatic, it usually presents with sudden intense and persistent chest or back pain or pain that irradiates to your back. Other symptoms of thoracic aortic aneurysm include trouble breathing, low blood pressure, loss of consciousness, shortness of breath, and trouble swallowing. Here is an X-ray of an aortic aneurysm compared to the patient's. We see here that the aorta is widened, the heart shadow is big, and the mediastinum is markedly widened as well. In this slide, we see that the patient's chest X-ray presents very similarly with the case of an aortic aneurysm. In this slide, we can see an enlarged aorta presenting as a radiodense mass that follows the configuration of the aorta. On the left side, we see a CT scan of a patient whose aortic aneurysm ruptured. The aorta can be seen as the white radiodense circle surrounded by a gray field which signifies hemorrhage in the thoracic cavity. The red arrow shows the thoracic aortic aneurysm, and the blue arrow is the blood in the thorax. The right side picture is the patient's CT scan, which shows a dilated aorta and some calcification. This is important because calcification is found to be associated with risk for rupture.
Now for the final diagnosis. So again, our patient is a 56-year-old male
who presented with chest pain radiating to the back and had previously uncontrolled blood pressure. He also experienced a tingling sensation in the lower extremities. The summary of the radiologic findings include widened aorta, dilated descending aorta, enlarged cardiac silhouette, and a widened mediastinum. Also on CT scan, there's a dilated aorta, contrast-enhanced blood in the aortic lumen, mural thrombus, and calcification in the aortic wall. So here is a tabulated form of all the differential diagnoses that we have discussed. In summary, for mediastinal mass, it can present as pain, paralysis of the diaphragm or vocal cords, and arrhythmia. It can also present as SVC syndrome, dyspnea, cough, dysphagia, widened mediastinum, obliterated retrosternal space, and hilum overlay sign. And lastly, for aortic aneurysm, there's sudden, intense, and persistent chest or back pain. It is important to note that risk factors would include history of uncontrolled and chronic hypertension. There is widened aorta, dilated descending aorta, large heart shadow, and widened mediastinum.
Comparing the presentation of the patient with aortic aneurysm, which would present as an abnormal outpouching of the wall of the aorta, sudden, intense, and persistent chest or back pain. Risk factors include history of uncontrolled chronic hypertension, widened aorta, dilated descending aorta greater than 4 centimeters, a large cardiac shadow, and a markedly widened mediastinum. So our final diagnosis is aortic aneurysm.
So now let's discuss the pathophysiology of aortic aneurysm. So we divided this into two major parts. So for the first part, we discussed how the development of aortic atherosclerosis came about, which is the most common pathologic cause of degenerative aortic aneurysm. So initially, the patient presents with coexisting risk factors for diseases of the aorta such as his age, 56 years old, of male gender, and of course, his uncontrolled hypertension as exhibited by his uncontrollable blood pressure. So his hypertension then will expose the blood vessels to high pressure and shear stress, and at the same time increasing the permeability of the aortic wall to lipoproteins, which will in turn lead to injury of the aortic wall and lipid deposition subsequently. All of these conditions result in the development of radiologic findings of widened aorta and dilated descending aorta as discussed above. With these, there is a predisposition to plaque deposition, formation, and disruption within the blood vessel, leading to the formation of intraluminal thrombosis, presented as contrast-enhanced blood in aortic lumen, as suggested in the CT scan. All of these lead to the development of aortic atherosclerosis.
So for the second half of the pathophysiology, we will be dividing it into three parts. From the first half, we stopped at the development of aortic atherosclerosis. This would trigger the recruitment of our leukocyte, especially the B cell and the T cell lymphocytes, pro-inflammatory cytokines, and macrophage infiltration. This would then lead to the macrophage-mediated activation of metalloproteinases. These metalloproteinases play a key role in the remodeling of the extracellular matrix. This would then lead to the degradation of the structural matrix proteins, namely elastin and collagen. Elastin and collagen, alongside the smooth muscle, are arranged in concentric layers in order to withstand arterial pressure in the aortic wall. To continue the structural matrix protein degradation, on the left side would be the continuous elastic degradation, cyclic strain, and elevated wall tension for years will lead to progressive aortic dilatation. As we all know that elastin serves as a medium for pressure wave propagation to help blood flow. So on the right side, we would see that continuous collagen degradation for years will lead to the weakening of our aortic wall or to changes in our extracellular matrix and the depletion of vascular smooth muscle cells. We all know that the collagen in tunica media and externa of the blood vessels creates strong and flexible blood vessels that maintains elasticity and keeps good blood flow. So these changes will lead to the increase in osteopontin. Now, osteopontin has been associated with changes in the extracellular matrix and depletion of the vascular smooth muscle cells, leading to aortic aneurysm development. This is according to a journal or a study by Konstantinos Philis et al. And three other journal articles. So the increase in osteopontin will lead to the calcification in the aortic wall, which was noted earlier by the hyperdense calcifications in the wall of the great vessel, as pointed out by the three red arrows on the bottom right corner. This leads to the weakening of our aortic wall. So, from the left side, we have the progressive aortic dilatation, and from the right side, we have the weakening of the aortic wall. These two factors will then constitute our aortic aneurysm. So for the development of aortic aneurysm, further expansion will then lead to the compression of adjacent structures, especially the spinal cord. In this case, chest pain radiating to the back and tingling sensation on lower extremities will be experienced as manifested by our patient, FG. So on the left side, further expansion would lead to widened mediastinum, which can be seen at the upper left radiologic finding from our patient, demonstrated by the red arrow, and enlarged cardiac silhouette. This would then lead to rupture in worst case scenarios. So that is all for the pathophysiology. I hope you enjoyed listening. Thank you very much.